Dr. Netski, thank you very much for being here for the podcast. We're going to talk about your journey that you've had into your current position, so we'll talk about that. We're also going to talk about mental health and leadership. And one of the things that's interesting to me about leadership specifically for you is because you just went recently through the ELAM program, so I'd like to talk about that too. We're going to start in Fernley, Nevada. You grew up there. One of the things that was interesting, so first if you could tell folks where Fernley is, and then I'm interested in how your family got there in the first place.
Well, thanks, Mark. I am a native to Nevada, and my family has been in Nevada for many generations prior to that. I was only in Fernley for the first 3 years, and then my family moved to Reno. For those of you who don't know, Fernley is about 40 miles east of Reno. And so when I was growing up, it really was just the stopping ground between Reno and Fallon, which is about 60 miles east of Reno.
The two metropolitans.
Metropolitan area of one of, I guess, the less rural part of Nevada now that Reno is growing so much. So growing up there, I don't remember much about Fernley, but I had grandparents and other family members that lived there for a very long time, and so that's so those are my memories of Fernley. My family spent a lot of time in Fallon. Prior to that, they were in more rural areas of Nevada, and came over really as pioneers. Spent a lot of time doing mining and other kinds of things. And then after growing up in Reno, I went to UNR for undergrad, which was just an outstanding opportunity, and then stayed on there for medical school.
So I'm actually really interested in why multiple generations back people moved to Nevada, right? So you said pioneers, and did they come here? First of all, where did they come from, and why did they come out here? Was it for mining, or did they just happen to do that when they came out?
It was the Great Migration West, looking for opportunity, looking for land for farming, and then during the time of the Great Comstock Lode, when there was a lot of opportunities for mining in areas around Tonopah and other places.
How many generations back?
Gosh, my my great grandma grew up in Lund, which is outside of Ely, Nevada, which is in the northeastern part of Nevada. Yeah. And was she born there? Was she born in Utah? Boy, I would have to pull out the papers to say, but so it's been at least since the 1800s.
Yeah. Well, it's, I mean, we're such a new state, relatively speaking. So somebody that far back that's early on. Okay, so you grew up in Fernley, but you moved to Reno. Your family chose to move there for work, or for what reason?
Just work, opportunity, moving to the big city.
Is your family in academia as well?
No. Mm-mm.
Okay,
no.
So you were kind of a trailblazer there.
Yeah. My grandmother was actually a nurse graduate from UNLV many years ago, when UMC was called Southern Nevada Memorial, and then and so she graduated from the UNLV nursing program, but she would be the only person in healthcare.
It's, so obviously we've known each other for years. It's really interesting to me. We've never talked about this, and I knew that you were from Nevada, but I didn't realize how deep the roots were, which is really cool that you and your family have been here for generations, literally for generations. That's really neat. So the nurse piece is interesting because we're going to talk in just a minute about how you got into the area of psychiatry, and it was a nurse that was inspirational here, right?
Well, getting to the path of psychiatry, you know, some people when they start medical school, they think this is what I'm doing. I was not one of those people. I had done a lot of work volunteering with geriatrics and all sorts of other kinds of things. When I was an undergraduate, I worked in a methadone treatment center. I worked as a volunteer in an emergency room. I was a pharmacy technician prior to going to med school. You know, all sorts of things.
Yeah.
No idea what I wanted to do. Maybe I was thinking neurology or something like that.
Can I ask real quick? When did you know you wanted to go to med school?
Oh, I just knew. I knew
Always.
from day one.
Yeah.
Day one of college.
Yeah.
Like this is where I'm headed.
Biology major, right?
Yeah.
Magna cum laude. Congratulations. Okay, sorry. You knew from the very beginning there was just something about it. This is what you want to do. Okay.
Yeah.
And you're all over the
So I had a lot of
field.
experiences.
Yeah.
I worked in a paternity lab. I worked processing as a technician, processing rodent blood samples. I mean, I did.
Wow.
It was a great time. Undergrad, it was a great time. I had all these different experiences, and then as you go through medical school, you start eliminating things off your list that you think are perhaps not a good choice for you based on, you know, just your affinity to the specialty. And then you have some moments where you really think, this is it for me. And for me, it was really when I was doing surgery, and then the rest of that year. But it just so happens when I was doing my clerkship in surgery, we had a lot of very medically ill patients who had some serious mental illness, schizophrenia, and they were highly symptomatic. And I just realized that was my comfort zone, right? Being able to develop good methods of communication, being able to see the person behind the illness, and really understanding what the health disparities are that can develop if you have unconscious biases towards people with mental illness. You fail to be able to communicate because of them being, you know, very symptomatic. And it's not unusual for the average person in healthcare, whether it's surgeon, primary care, general med surg nursing, to have some reluctance to work with people who are very paranoid or are hallucinating, or maybe have some aberrant behavior. And so I've realized at that point, and then throughout the whole rest of the year, you see the psychiatric conditions in everything else, right? Whether you're doing internal medicine or other kinds of things, you see the underlying impact that illness can have on patients.
It's interesting the way you're describing, because I hadn't thought about it, but it becomes a potential thread through any of the specialties. And in particular, I think some of the trauma-related specialties as well. So, yeah, and what was it? Do you remember what it was exactly? Like, was it that you felt like you could reach the people? What was it that really attracted you in this direction?
So I would say the moment where I said, this is it. Like, this is it. And at that time, psychiatry, I mean, it is a very popular specialty now, right? The match is very competitive. Medical students are really wanting to go. But, at that point, psychiatry was not the specialty that was thought of as very competitive and held in high regard. It just was. You would sometimes have comments where people would say, well, I guess we need smart people in psychiatry too. Yeah. So I'm glad you're going into this. But it was sometimes, to some of your mentors, it was a bit of a letdown. But I would say the most memorable moment was a patient that I was working with in the hospital who had schizophrenia for quite a few years, was very medically ill, but she had a picture of her where she had graduated with her doctorate in computer science.
Oh, wow.
And so she would say, this is who I am, right? I need someone to help me get back to like this is what I'm capable of. And so you thought, wow, these people are saying these people are us. I mean, we all have vulnerabilities. We all have periods of time where we may have some really serious needs, and being able to embrace that instead of feeling like society is turning your back on you at that point is really important. It's very important now. I mean, mental health is now in the spotlight where it's kind of been in the shadows for a long time.
Yeah, it's like that story is touching to me. Like I can see how that would shift your way of thinking because, and I'll naively, I'm thinking, well, you've got this picture, and the fact that that person recognizes that that's who they are and that's who they can be, but something has taken them away from that, is really remarkable, right? Because a lot of times I think we just think about people who have schizophrenia or some mental illness, that they don't have a foot in reality enough to be able to make those types of comparisons. I just heard a podcast actually last night where the speaker was talking about schizophrenia and talked about it as being on a spectrum. And so what you're talking about is somebody who is sort of on that part of the spectrum where they're able to recognize their self in sort of their best way. And I had never heard of it like that before, so that's really fascinating.
You could look at schizophrenia the same way that you can look at diabetes, the same way that you can look at any number of conditions from diverticulosis. Whether if you recognize it and you have a good management plan, then you have a good chance of the illness not controlling your life. You can control, with maintenance, you can control a lot of symptoms of the illness. Not 100%. Doesn't mean that you don't have it. Doesn't mean that it couldn't still cause disruption and disability and that you don't still need supports. But with the right tools in place, the outcome can be very different. So
this actually extends to one of the topics that we're going to talk about, and that is the future of mental health from a couple of different perspectives. One is, what trends do you see that are happening in mental health and or mental illness? And then the other side of it is, what are the things that we're going to be doing a few years down the road that we're not doing now, or at least not in mass that we're doing now? What are your thoughts about that?
Well, it's an exciting time, and it's also a little bit of a scary time in the world of mental health. The last few years, partly related to the kind of outcry because of COVID, but even a little bit before that, the recognition of mental illness as an important topic has really made its way up to the forefront of public health, topics. The stigma related to mental illness for our generation compared to the younger generation is like apples and oranges right now, where in my earlier career, working with professionals, the stigma, what's going to happen to me? Do I need to declare this on a job application? What's my family going to think? People don't want me to take medicine, or psychotherapy is for people who are weak. All sorts of ideas, because people were afraid, so they made up stories about people with mental illness being different. But now, all of the campaigns and the ease of being able to talk about how you're doing with your mental health in our current generation from teens up through mid 30s is very different. So that is exciting. If you think back to what the stigma was associated with some very common conditions like cancer, like breast cancer, right? In the 70s and early 80s, people didn't talk about breast cancer, and there wasn't a lot of great treatments, and the treatments that were available had some stigma some post-surgical stigma associated with it, and so it was kind of hush-hush. So people were were really marginalized as far as being able to get support. And through big public health campaigns, understanding more, we've really been able to make tremendous inroads to the survivability of cancer.
Mm-hmm.
So this is where we are now with mental health. The amount of funding that is going into different kinds of treatment, it's obviously not where I think it should be. But there's still a lot of barriers to mental health treatment, but far superior to where it once was, but also the amount of attention that's now getting paid to research on different kinds of diagnoses, treatment modalities, the impact of childhood trauma. All of those different kinds of things are going full speed. So what is the face of psychiatry treatment going to look like in mental health treatment in 10 years and 20 years? I would estimate it will be very different than what it is right now. Hopefully, for certain kinds of conditions like depression, there will be some more easily accessible rapid treatments
Mm-hmm.
compared to what we have today.
So a couple things follow up on that. One of them, you had talked earlier about how when you were in med school, psychiatry wasn't as competitive as it is now, as far as the number of people who want to get into the field. What's the lag? So a couple of questions about that. One, why do you think it's changed? What's the lag between when it started to become more and more competitive? And to be clear, obviously you're a great example. I'm not saying there weren't great people in it.
Mm-hmm.
Just, that wasn't the specialty that a lot of people were going to. And so you've got a little bit of a lag where all of a sudden it started increasing people into those specialty programs. And then slightly following that was people being more open and about discussing mental illness and mental health. What was the lag between those two? Like, what do you think drove that? Some of it was, like you said, it was the public service announcements. But there, almost always, breast cancer is a really good example of this. It's usually somebody, a celebrity, these kinds of things that put a face to it that all of a sudden start driving some of that, the awareness as well, right?
I think there likely are many factors. One is that careers in psychiatry are outside of just the state hospital or private practice,
Mm-hmm.
right? There are a lot of opportunities for people in psychiatry to have a variable, kind of practice where you don't just have to do one thing all the time. So that is really appealing for folks. The equity and pay for psychiatry careers has greatly improved over the last, I would say, probably 10-ish years. And so that makes, med students look at all of these different metrics. But the other part is I would say the other two factors. One is work-life balance.
Mm-hmm.
Psychiatrists have more ability to have some control over the number of hours a week that they choose to work, because there are less responsibilities for on-call surgeries, some of the necessities of a trauma surgeon or an ICU doc, or some of those things that are inherent to those specialties. But the other part is, if you think about what all med students say on their med school interview, it's that I want to be able to get to know people, I want to take care of patients, I want to take care of families, and I want to be able to deliver some whole person care. And psychiatry allows you to have the opportunity to really get to know your patients for a long period of time and help them really develop a plan for good insight, maintenance of their condition, and you get to see them achieve a lot of successes. in their life.
It's, you know, it's interesting how some of the metrics of students change through med school. So like you said, you know, they all come in wanting to help people.
Mm-hmm.
And then one of the things that we know, for example, is that empathy scores decrease through med school, which probably there's a practicality to that to some extent. You need to be able to be have enough distance so that you can make, you know, objective decisions. But I wonder if it, in some cases, maybe goes too far, that there's a lack of empathy. But it's interesting. I think back to the story of you with the lady with the picture. And that was, I mean, I've seen you as both an objective person but an empathetic person as well. But in that case, that was sort of like a spark of empathy. It was as you told me the story. I'm like, oh, wow, now I feel a different level of kinship with her than a schizophrenic in a hospital, right? And so I wonder if they had, if med students had experiences like you did, where you connect with that person, if that would be something just like it did for you that would shape their, not only their view of who they're going to work with and how they're going to work with them, but just overall empathy as well. You know, a friend of mine told me one time, she's a physical therapist, and she said every patient that she works with, she thinks about them as a potential family member, and she treats them from that perspective. So
the good news is med students are not all the same.
Yeah.
And somebody's desire to say, I want to be that doctor that saves that patient in the first hour after a trauma, or I want to see that, be that person that really helps people with their mobility, because, you know, we know how bad it is after an elderly person breaks their hip, but I am committed to, you know, helping that person get their quality of life, or, you know, being able to, you know, say, I want to stamp out heart disease, right? And I felt so committed to giving people a longer life. And so we, you know, based on, you know, your patchwork of what makes a, you know, person a person, they're all going to have, you know, have that little inlet to what, you know, keeps your fire lit to keep you going, because, you know, medicine is not an easy career path, and there are a lot of things that make it, the challenging parts sometimes aren't seeing the patients. It's, you know, more of the practice of medicine, the business of medicine, that can make things a little more challenging.
So my mom, we've talked about this, there are 8 kids in my family, and my mom told me one time, when you all were young, I tried to treat you all the same, so nobody felt like they were being treated different. And then you grew up, and I have to treat you like people. And you just reminded me, when you're talking, you know, people are different, and they respond differently, even to the same situation. So, yeah, I think it's cool when people, like in your case, so obviously match to the places where they can make their contribution. And that's really my hope for a lot of people, right, in medicine and not, that we're in a place where we feel like we can make a contribution.
Yep.
So one of the things, you know, you talked about some of the future of medicine areas. In a lot of areas of medicine, it's being automated in, for example, robotic surgery, and then the genetics, using genetics for cancer treatments and so forth and so on. So it's really almost the technology that's moving that field forward. Do you see any of that in psychiatry?
Oh, for sure. I mean, there are a lot of projects that are happening trying to better, really be able to better match, you know, neuropeptide changes, brain changes, mood changes, EEG changes, like how can we do a better job, you know, predicting, preventing, monitoring, other than what the patient tells us. So a lot of neuroscience research on the brain happening right now. In addition to that, there is quite a movement using artificial intelligence, meaning using apps to try to be able to help patients monitor their behavior, and is that predictive of how they're doing? So that's a tough area, because you're thinking, well, do I want people to know? Do I not want them to know? But the areas that the companies that are looking at, these kinds of things will be able to get baseline information on you, and then based on how many times a day you text, or what is your geographic area, or other kinds of things, they can make some smart inferences of, how are you doing today? You haven't really gone out much. How is your mood? And to be able to do some inter-appointment monitoring. I don't have firsthand knowledge of any of that in action, but we've talked to a lot of app developers and a lot of conversation about how can we do a better job giving people access to how they're doing, and some tools, because the access to treatment is really lacking in a lot of areas right now. We really are at a tough point with mental health shortage for all various kinds of clinicians, psychiatrists, psychologists, and everyone on both ends of that, and it's not going to go away anytime soon.
Yeah. It's interesting. So the app conversation, it's, some people would suggest that there are certain social media platforms that are actually hurting the mental health of the world to some point, right? And now there's an app where you're using essentially AI and big data to be able to determine, right? And it's not the tool necessarily that's bad, it's the abuse of the tool that becomes the issue, right?
So who knows what will happen with that? As we know, social media, we're just so tied in with data and our computers and smart devices. What is going to happen with our personal identities and all the data? That's a question for someone else.
Yeah, absolutely. Yeah, but I do like the idea, and what you're saying is that both, the conversation about mental health is a more open conversation, and when it's, out there, then we can address it more as well. So, considering the technology aspect of future mental health work and what the other trends that you've talked about, how do you think that changes how we train individuals to be mental health professionals?
Well, at a core, people have to understand the illness, and they have to be able to understand the impact on people, and they have to understand, the various, kinds of treatment modalities. What I would expect that we'll continue to see in the future are more opportunities for specialization. If somebody is going to be, so just like in psychiatry or psychology now, right? Some people do specialized testing. Some people work with forensics and, specialized court system that is kind of outside of what I would do, working with patients. And, some people work with just kids, and some people do different kinds of specialized psychotherapy, and I would estimate that would fall along those lines, and then maybe someday there will be a whole kind of technology of mental health arm to all training programs.
So, okay, I have one more question for you about this, and I'll put it out there if you aren't comfortable talking about it one way or the other. Although I'm preambling this question because it reminds me a little bit, paralleling what you talked about, how there's been an evolution of people being more open to talking about mental health. One of the things that has been in mass media lately is about, like, for example, the book How to Change Your Mind, and utilizing psychedelics for treatment and psychiatry. Do you have any thoughts about this and how that might impact some of the treatments going forward?
Well, the good news is there is a lot of research being done on how to safely and effectively use a lot of the substances that are out there, certain kinds of psychedelics like psilocybin and also cannabis, right? We have these substances that are out there that are being used, and because of kind of the war on drugs and the kind of prohibition of being able to think about these as medicinals has been in place for so long, we don't know kind of what we don't know. So the good news is there's a lot of research being done on psychotherapy that is assisted by hallucinogens for people with PTSD, and so this will be a really important area. We have some conditions that are very hard to treat, trauma-related, complicated illness, complicated PTSD. These are very complex conditions. There's not just one pill or just one therapy that works for everyone. And we need to continue to push the envelope to be innovative so that we can help people come back to their trajectory where they're feeling, comfortable and in control of their life again.
I keep coming back to the story that you told and help people come back to that picture that they see of themselves. It's interesting to me because, it goes back to what we were talking before. It's not the tool that's the problem. It's the abuse of the tool that becomes the problem. And, social media is this way, potentially using psychedelics is this way, and so forth and so on. You could go down the list. There's a sweet spot probably for a lot of things, but if you abuse that sweet spot, it becomes problematic. So, okay, so let's switch gears a little bit, although I think we maybe need to do another podcast just to follow up this topic of mental health leadership. So you've been a leader in your field for a long time. You've been a department chair at UNR School of Medicine, at UNLV's Kerkorian School of Medicine. You've recently moved into an additional, I'm not going to say a new, but an additional position. So if you can talk a little bit about that, tell folks what that is. And then in general, what your style of leadership is, where did that come from? And then what's unique in your situation being a female in leadership positions? And this gets us back a little bit to the ELAM topic that we talked about in the beginning. So.
Oh, that was a mouthful.
Yeah. I realized as I was getting all the way to ELAM, I'm like, wow, I should have listed those questions. But
so I don't think people, kind of start their journey saying, I am going to end up here. Or I'm going to end up as a chair or as a dean, or they follow, kind of what their, what their likes are. In moving back to Nevada, I would say whether it's my passion or my Achilles heel is education, right? I really love working with medical students. I am passionate about trying to improve the healthcare landscape in Nevada. When I moved here in 2007, there were more psychiatrists in the hospital I came from in Maryland than we had in our whole state.
Wow.
All right. It was a shock. It was, I thought about getting back in the car and going back, but that didn't happen. So, kind of coming back here, and I had a lot of roles, right? I was a clerkship director, an associate program director, and I ran the service at UMC for psychiatry consultations, and then you reach a crossroads where when opportunity presents itself, you think, well, I didn't really think about this, but can I do this job? And what do I have to offer? And, hopefully what you have to offer is a commitment to the mission and a desire to, see all boats raise. So if you have the ability to help people see the best versions of themselves and to help them succeed and be able to maneuver the internal kind of internal system and internal landscape at whether it's your business or your institution, so people can achieve great things, right? They can become great educators and great doctors and, do great research, and you can help put the landscape together for them so they can maneuver that. Then that's a picture of success. I like working with people. I have always just had a pretty easy time and easy manner in getting along with folks. I don't like conflict, and so I really try to work to prevent it, work around it, find systems for people to be able to communicate better. Most conflict comes from misunderstanding or people feeling disrespected, and so being able to prevent that from happening is really important. Leadership is also a case of sometimes you don't know what you don't know. So people can have great skills, but it requires investment from the person that wants to go down this track, but also from the institution to help put resources in place through opportunity, but also through some mentorship activities to be able to do that. This last year, I was in the ELAM program, which is the Educational Leadership for Academic Medicine program, which is a leadership program for women in academic medicine that's run as a partnership through Drexel University, which many years ago was the first college that accepted women into medical school. And so they do a really intensive year-long program for women that are in medicine, dental medicine, public health, and also in pharmacy schools now. And the experience is really impactful on many levels. One, through networking. It's fantastic because you meet people from all over the United States, and they're all there for the same reason, right? They're all there to be able to just figure out how can I be the most impactful and the best leadership version of myself, and where I am, or take what I know now and be able to advance myself to another role and be able to push the envelope of academic medicine. The program, it's year long. You meet 3 weeks in person throughout the year. You have a learning community of people that are from all different kinds of backgrounds, different specialties. Hopefully you're close to the same time zone, because that can make meeting every week a little difficult. And you go over different ways of analyzing your organization, your own leadership styles, understanding other people's kind of leadership and communication styles, organizational structure, more of the business part of medicine, economics, financial indicators, strategic partnership methodologies, and kind of all things in the middle of that. There's a lot that goes into running an academic health system, and being being in the role of kind of being the steward of any part of the the mission, whether it's research, clinical, academic, community engagement. So having that experience is during the year is a little bit like drinking out of a fire hose, but then you take it with you, and as you keep going, you realize, oh, now I see, now I can use pieces of this, or I'm seeing this problem from a different viewpoint. But also you have the opportunity to really stay in close contact with your learning community and other they call them ELUMs, alumni of ELAM. So you have a great network of people that you can lean on to get advice, ideas, and having an equal playing field for women in academic medicine is very important. Right now, there's a smidge more women going into medical school than men when you look at the pure numbers. But if you look at the numbers when it comes to deans, vice deans, you're looking at, depending upon what institution, you're looking at anywhere between 10 and 20%. Nationwide, they haven't achieved over 20% at the dean's level. So that's really important, that we need to have leadership representation that looks like who we're representing.
And do you think that, well, I'm not going to suggest, why do you think that is, that women are underrepresented in some of the leadership roles in academic medicine?
I think there's a lot of reasons that that come from other responsibilities that women have throughout their life, with being a lot of times being the primary caregiver. Sometimes, like, I'm very fortunate where we're 50-50 in my family, and so that's really, really fantastic. And there's been a lot of years where it's been probably 70-30, and I was not on the 70 side. So I feel very fortunate that I've been able to take extra time to follow some of these leadership opportunities, but not all women have that opportunity. And if you leave the field for a while, if you take some time off, or if you go part-time for a while, being able to re-engage, sometimes is difficult. And people wonder, like, well, is that the right person? Or maybe this person, all the unconscious biases come out. And sometimes people are overlooked. Not appreciating some of the experiences, that you have when you're away will make you a better leader.
It's interesting. So the discussion of, you've been away, and then can we count on that person being here? You hear that one often, but rarely do you hear the conversation about, what were the things that you learned while you were away that could help with the current situation. And so, as a department chair for several years, and now you're in a new role, again, an additional role because you're still the department chair. Can you talk a little bit about your new role, and then how the ELAM experience has helped you with that?
So the new role right now is the interim vice dean of clinical affairs, and chairing the board of UNLV Health, which is our faculty practice. So it's kind of doing some of the things that you do as a department chair, but at a macro level, but a lot of it is very much the same. Do you have the right people in the right positions? Do people have a clear directive as to what they should be doing, and how that loops back and benefits us as a whole? Because everybody is part of this mission. Whether you're the person who is responsible for being that first point of contact, answering the phone, to somebody who's maybe really scared to call the doctor because they don't know what's going on with them, or you're the person taking the blood pressure, or the person that is responsible for making sure the bills go out and that we're getting money, or the individual that makes sure we have a good sign, and that we have good chairs in our waiting room, to our physicians, and everyone in between. Without any of those roles, the ship sinks. Yeah.
Do you know? You've probably heard the story of the Kennedy, John F. Kennedy at I think it was at Cape Canaveral, and he was going through on a tour, and he stopped back to talk to the custodian. So they're going through the tour, and he sees this gentleman who's mopping the floors, and he's just doing it with such passion. Like, you could tell that he's really paying attention to what he's doing. So Kennedy dropped back and he said, "Excuse me, can I ask you a question?" He said, "Yes, of course, Mr. President." He says, "What do you do here?" And the custodian said, "I help send men to the moon." And of course, Kennedy understood exactly what he's saying. If he doesn't take out the trash, if he does, if the facility isn't the way that it should be, it becomes a problem, and so forth and so on. So everybody, having that North Star and understanding what that North Star is so very important as well. It's interesting. I think, as a department chair, I think you still do a phenomenal job. Your team all seem to know where the North Star is, and I think that's coming about as well through the practice plan and the organizations that you're in charge of. How do you do that? Like, how do you specifically make sure that people understand they're sending a man to the moon, right? This is their North Star.
Well, I mean, one is communication, right? So I guess I'll talk about the department level. I feel like the part with the UNLV Health, we've taken on some big challenges in these last 8 months, and we're doing some big things to try to actualize our potential. But I still have a lot of things on my list, right? That I feel like I could do better, and where I think I could really help make the possibilities better and easier for other folks. Mm-hmm. At the department level, it's you're really being able to appreciate people as an individual. I know people's personal situations. I know, when somebody's going to need time off, what parts of the year they need a little more flexibility in their schedule, what they're passionate about. I also know what their weaknesses are, so that I can help them stay on top of those things, whether it's completing medical records, doing student evaluations, feeling anxious, putting educational material together for a new class, being able to give difficult feedback to employees. All of those. There's a lot of things about work that are not on the top 10 list of the things any of us would like to do, but if you ignore them, they become big. So being able to make people accountable and give them the tools and the support so that they feel comfortable doing that is really important.
It sounds like a lot of the things that you just mentioned, it sounds like a lot of those are things that you know, that you have in who you are as a person. And then on top of that, some of the work that you did with the ELAM group adds tools to that toolbox, right? But if you don't have both of those, it's just not going to be a great system, right? Because you could have the tools, but not the humanity of it, which is cool. So it's one of the reasons why I think you're a perfect person to go through the ELAM, and then you get to, the ripple effect of that becomes huge as well. So we're out of time, unfortunately, but I really enjoyed talking to you. Thank you so much for being here. Any last words of advice that you have for us?
Well, I think we're in a great position to make a tremendous impact on our state, and our road has not been easy, and the road of medicine, I would say, is probably not going to be any easier moving forward, but it's worth it, and if we're all in it to win it, then I think we're going to be able to see great change moving forward.